Start again. Hey, vault lovers, let's talk about some brains. Specifically, let's talk about infections of the CNS system. Again, one that you probably don't get super often in EMS, but one that you're actually probably exposed to more than you kind of realize. So we talk about, like, all sorts of different infections right now. COVID's the hot thing. We talk about pneumonia. We know about septic shock and urosepsis and all that kind of stuff. We talk about all these big organ systems that people get treated for in an emergency sort of standpoint, or in a hospital or an ICU kind of standpoint. But when is the last time you really talked about infections of this big organ system that runs all through your body, that does a lot of stuff, called the central nervous system? I bet it hasn't come up very often. But these are significant infections. They're not super common, but they're really devastating when they happen. So I wanted to give you a brief overview of them. When you look at these things, you can basically group these down into basically three different categories. There's the things that are the meningitises, there's the encephalitis, and then there's the structural infection somewhere in the CNS, like an abscess. And for the most part, the CNS infections kind of go through this, and there's varying flavors of each of those. But but they all kind of fall somewhere in there in terms of where you get infections in your central nervous system. Let's look at a case, shall we? You are called out to a 23-year-old female with IV drug use. I'll get myself out of the way here for a second so you can see all that. This person has had lower neck pain and upper back pain for a couple of weeks. You've made a number of runs. First it was for overdoses, and then this person started complaining of back pain. The local hospital knows them real well because they've come in 6 or 7 times for it. They've had a number of visits. They were sent home with ibuprofen, Robaxin. Somebody even gave them some Norco to use at home, some hydrocodone. And the patient says it's not really gotten better, and so subsequently she's taking a lot more heroin recently, injecting specifically. Today she called EMS because she feels like she can't drive to the ER because she feels like her legs are weak and her hands aren't working very well. And you ask her to hold her hands up, and she holds her hands up and kind of does this thing, but she's able to kind of get them up there, but she doesn't seem to be moving them super well. She's just kind of able to do like that sort of thing. She's not really able to pick up stuff. That's the basic neuro exam that you get. And she won't or can't lift her legs off the bed when you go in and try to get her to stand up and walk to the cot. So when you try to ask her to turn her head side to side, she cries loudly, and whenever you try to lift her forward, she hollers whenever you ask her to turn her head. You take her to the local hospital. She's got the vital signs that you see there. For the most part, she's just tiny bit tachycardic. And then that last one, that 101, is her temperature. Tiny bit, again, oops, sorry, got a couple of people sitting in there. I'll make sure everybody gets muted here. She's a tiny bit tachycardic and a little bit febrile. And you are called back to the hospital about 6 hours after you take her there with a request to transfer her to another facility. And you're called to transfer to a center for a neurosurgical evaluation because they found an abscess. And you say, well, the nurse says, yeah, an abscess on her neck. And you think like, okay, well, I noticed this little like ditzel underneath her chin, but why does that need a neurosurgeon? And the doc walking by says, wait a minute, no, not an abscess on her neck, an abscess in her neck. And pulls up this image here and points out, hey, well, here's the spine. This is we ended up getting an MRI of her. There's her spinal cord going down here, and then all these arrows that the radiologist puts on you, that's usually badness, and highlights this area right here. Says that's the abscess. So this is an example of a spinal epidural abscess. This is an abscess in the epidural space around the spine. If you remember a little bit of like neuroanatomy, you have basically like the dura, the big heavy covering that surrounds everything, and surrounds all your like important, actual nervy type parts. That's sort of the insulation. And then the epidural space is between that and the periosteum, basically, between that and the bone. And so you can get abscesses that form in that area. Oh yeah, there he is. So what is an abscess? An abscess is a walled-off collection of an inflammatory place where you've got an infection, basically. It's a pocket of pus, if you want to call it that, for lack of a better term. If it's not actually a pocket, if there is no pocket there and it's just infection or bad tissue, then you might call it a phlegmon. But an actual pocket is an abscess. So what do abscesses do? Well, number one, they become hard to treat because they're walled off, and so you can't really get stuff into them. Like antibiotics don't work real well. The area is acidic, so a lot of medicines don't work very well in that space. They also hurt like hell if you've ever had one. They're very sensitive, not only from the infection itself, but they also put pressure on things around it. And if this is, on your leg or on your thigh, it hurts because it's kind of pushing on the skin and making everything tight, and it hurts. But if you have them in another space, like in your spinal cord, where things are sort of walled off and they don't have space to expand out, then as it pushes on things, it can actually cause neurological deficits. Because the one thing the spinal cord doesn't like, while it doesn't like being, pulled on a little bit and that kind of stuff, is getting pushed on. Nerves in general do not like having pressure applied to them. And subsequently, when that happens, when you get this abscess forming, you can get a neurological deficit because it's pushing specifically, sometimes on a nerve root, but often on your spinal cord itself, as you kind of see from here. The thing to remember about spine stuff specifically is that it can take out, wherever the pressure is applied, it can take out function or sensation or cause pain at that level, but also stuff below it. It's sort of like a Christmas tree or a string of Christmas lights. Everything that kind of falls below it may get taken out as well, or may get affected as well, because you're pushing on the wires that run through that section. So, spinal epidural abscesses, they hurt. They are difficult to detect, and they can have devastating effects because if you smush on your spinal cord, you really cause it some problems. And here's just one more kind of groovy picture of it, really nicely delineated. Here is the spinal cord itself, this gray thing back here. The white stuff is CSF, and then the two arrows pointing at the little lens-shaped thing there is the abscess itself. One of the other things that you can kind of see on here, maybe a little bit, you see that little bit of white piece that's extending onto the spine itself? That's where they're starting to get some osteomyelitis infection in the bone. Sometimes you get this in the vertebra itself, sometimes you get this in the disc space. And one more time with feeling, when you take out a spinal cord level, you often not only take out that part, but the nerves immediately below it as well, if nothing else, if not all the nerves below it. So if you have an abscess at, say, C6, the C6 nerve root, then you can take out, of course, C6, which is this area of sensation right here, and usually this happens bilaterally. But you can take out C6, but you also end up often taking out kind of everything below it, at least immediately below it, because you're pushing on all the wires that run through it. And there's a groovy picture of some awful osteomyelitis that spread what was initially a spinal epidural abscess that then spreads into the vertebral column itself. And you can imagine that is bad. Infections in your bone, always bad. But because your spine is such a load-bearing thing, a lot of times these guys get fractures once they start to get some instability in the spine itself. I can distinctly remember a gentleman, unfortunate cat, who had tuberculosis and had vertebral osteomyelitis, and basically every time he would stand up and get out of the hospital, if he sat down too hard, he would have a fracture, and there was nothing anybody could do about it. He just basically pulverized his entire lower back. Awful disease. He was a really nice guy too. That's always the way it is. Anyway, bad stuff, spinal epidural abscesses. Why do they happen? Why the spine specifically? Well, there's basically three different ways that it happens. One is direct inoculation of the area with a bacteria. So, a surgeon takes a needle or takes some sort of device, whatever they have, a saw of some kind or a spade or something, licks it and then shoves it in your back. And you directly inoculate that area with bacteria. It can happen that way, or it could be from an epidural injection, something like that. Pretty rare, but it does happen. That's maybe 10% of all the spinal epidural abscesses. And by the way, these aren't super common, but they are out there. But for all the problems that they cause, you just actually don't see them very often. Anyway, direct inoculation is one way. That's about the least common way. Spread from another local infection in some other places there. So if you have a retropharyngeal abscess, the posterior tissues of your neck and esophagus and your pharynx can spread backwards and cause a spinal epidural abscess, or a psoas abscess. The bacteria can spread in from someplace else. It could happen from there. But the most common way is usually hematogenous spread. So you have bacteria that seed your blood for whatever reason. Either you're an injecting drug user, or you've got bad dental infection that it is very vascular, and so the bacteria jump in there and they run someplace else. Usually it's a skin sort of thing, but bacteria enter your blood, and then they get into this plexus, this basically very low flow collection of blood vessels on the venous side. That allows the blood to just kind of sit, chill out. You can think of it kind of like an eddy in a river where stuff hits and then it just kind of, drifts down to the bottom, kind of settles on the bottom. Bacteria do the same thing where there's not high flow. And so this particularly happens in the space around the spinal cord in what's called the Batson's plexus or the vertebral plexus there. Again, what's the best way to make sure that happens, to get bacteria in your blood? It's to take a needle and squirt them on in there, as injection drug users do. So this is probably the most common setting that we see in the emergency side, is folks that are not real connected to the health system who are injecting drugs, and then they inject the wrong bacteria in there. It finds a low flow place like your spine, and then it sets up shop in that spot. So other folks that might have things like endocarditis, they have a compromised immune system. So end-stage renal disease, cirrhosis, diabetes, big morbidly obese people sometimes get these as well. For the most part, though, it's almost always very often injecting drug users. Why might you think that somebody has a spinal epidural abscess? It unfortunately is sort of difficult to figure these things out, because what do these people present with? Well, they present with pain most of the time. Most of the time, the presenting symptom is going to be that they have pain in their back, neck, wherever. Unfortunately, back pain is a super common thing that we see in an emergency department, so that may not tip you off for it. And then the classic addition to that is that they also have fever and a neurological deficit. Unfortunately, only like 1/3 of patients present with isolated back pain. No other symptoms, just I have back pain, and they have this thing. Well, we see 10 people a day who have back pain. You've probably taken 2 people to the hospital on your last shift if you're in sort of an urban setting who complain of some kind of back pain. But only about about 1/3 of these folks will just have pain. 2/3 of them will have essentially no neurodeficit at all. So again, only about 1/3 of them. Fever may only be in about 1/4 of these folks. So all the classic triad, the things we're supposed to look for, aren't really there, and they could present with any of these things. Let's see here. There we go. 2/3 of these folks, again, have no neurodeficit as well, which is one of the things that you commonly look for and kind of tips you off. So it's probably not of too much of a surprise that only about 11% of people that have these actually get picked up on their first visit, and so they get delays. And the average person, depending on what study you look at, has between 3 and 6 visits to a healthcare provider or to an emergency department, often an emergency department, before somebody makes that diagnosis. So they are hard to find. It looks like everything else that we have. So 99% of people will have one of these things, but only about 1/3 actually have all 3 of them, if that. And then how do you make this diagnosis finally? These are folks that get transferred for MRIs if you're at a small shop that doesn't, or even a moderately large shop that doesn't have an MRI available. You see these people taken all the time. And most of them will not have spinal epidural abscesses, but again, it's a devastating disease if you don't get it, so it's really worth it a lot of the time that we will transfer these people out. So you may end up with one in the back of your ambulance, going to someplace for an MRI in the middle of the night. All right, treatment of these guys, I've talked a little bit too much about them, more than I intended to, but treatment for these guys is going to be primarily start with antibiotics, and depending on where they are and what the symptoms are, if they have a neurological deficit, if they have something that's obviously pushing on their cord and not just pain, then a lot of times they'll go in for surgery. And this is a depiction of surgery through one of the cameras. You see this is basically looking into a bunch of pus and granulation tissue. This is when you clean the pus out. Here's after you've started to identify the disc space, and then they go in and they shave out dead tissue and debride that. And depending on what's going on otherwise, they may need to do some fixing of the bones themselves. Although you wouldn't do that probably initially. That would be kind of later on down the road. But getting the pus out is the number one thing if it's pushing on things. A lot of these folks do get treated with just antibiotics, though. If they just have pain or just have fever and they don't have actual signs of things pushing on their cord, a lot of them will get antibiotics and not have to get surgery. By the way, afterwards, there's about a 50% chance that if you have a spinal epidural abscess that you have some sort of neurological problem going on that goes on later on in your life, whether it be continued pain, difficulty walking, etc., etc. So these are bad things. And the longer it takes to figure them out, the more established it gets. And once you start actually pushing on the cord itself, it's a bad sign. And unfortunately, that's the time when we catch a lot of these. So those are spinal epidural abscesses, one of the bad CNS infections. You've taken this patient now. Remember, this is the young patient that we were transferring for concern of a spinal epidural abscess. You took her, she's more or less stable. She's having a lot of pain. You give her pain medicine. Continue her antibiotics. Take her on to the neurosurgery center. You are called again on your way back as you are going back into town, going back into the county line. They say, hey, EC2, respond to the college dorm. We have another 23-year-old female now complaining of headache and neck pain. And so you arrive at the local, community or local state college dorm there, and you find a young lady who is complaining of headache and neck pain. Said, Mom, I guess, called her this morning to check on her because she'd been feeling kind of bad for the last day or so, a little bit of a fever, thought maybe she had the COVID, but, felt like a little stiff neck, just kind of sore in general. When Mom called her back today, though, she wasn't really making a lot of sense on the phone. She sounded kind of drunk, and Mom was concerned. She couldn't get a hold of her friends or anything, so Mom called the college, who then called you all. So you find this young lady laying in bed, and she opens her eyes to you, but mumbles answers. She has some purposeful movement with her arms to kind of cover herself back up when you try to take her blanket off, and cries loudly when you ask her to turn her head. You estimate her GCS to be something like 12, something like that. So she's definitely quite a bit altered. You get the vital signs that you see below, and I get myself out of the way here again, a little bit febrile. Breathing a little bit fast, and by the way, that's a true 24. An actual respiratory rate of 24 is actually pretty quick, and that would be noticeable. So a true respiratory rate of 24 portends something is going on. You can't tell what it is quite yet, but something is going on. And she's likewise febrile to 101, as we saw before. You take her to the local hospital and hand her off. Go back out, do your day, go back to the station, get yourself a cup of coffee. You're called about 6 hours later by the charge nurse from the hospital again, who starts asking a bunch of questions like, hey, who was actually in the back of the ambulance with this patient? Was anybody else in the room with her? Who actually interacted with her? And then she ends it with, well, you may want to get tested or checked, I don't know, something, but she had meningitis. So you probably need some medicine. And it's like, whoa, wait a minute. All right, what's going on here? Let's talk meningitis for a minute. There's a lot to kind of unpack with all that. When you go back to anatomy, as we often sort of do when we're describing these things, look at the anatomy of not the brain itself, but the stuff that surrounds the brain. So you have what I will broadly call, there's all this stuff on top here, skin and all these bony layers. That's the skull and all the stuff outside. Inside the skull itself, there are likewise more organs or more layers of stuff that are really important to the way these things work. So the meninges are the covering that surrounds the brain. And there's sort of three layers of it. There's the dura mater, which is the tough stuff on the outside that, like, if you, it sounds weird, but if you look at an autopsy, when they like peel the top of the patient's skull back, and then they incise this gray thing and pull it away, and it looks like some kind of membrane. That's the dura mater. It's tough, it's hard, and it surrounds everything, and it actually creates essentially the system of blood drainage as well as for CSF drainage of the head. And then there's the arachnoid mater, which is all these little bridging things that stand in between the brain itself and the dura mater. And then there's the pia mater, which is the thing that actually covers the brain itself. Okay, there we talked about it. Those are broadly the meninges, the covering of the brain. It's probably easiest to kind of understand that if you look at it in terms of where you get blood. So an epidural hematoma, I said that this is the dura, the meninges are the dura. An epidural hematoma is between that and the skull. A subdural hematoma is between the dura mater, the big thick thing, and the brain itself. And then a subarachnoid hemorrhage is underneath the arachnoid up against the pia mater, so basically against the brain tissue. Those are the places that you get hemorrhage. That essentially opens up the different spaces in between those layers of meninges. So that's presented as, here's an interesting thing. Let's move on. Instead of bleeding, what meningitis is an inflammation of these, and it's often due to infection, although it can be sometimes due to just irritation from some things. So again, outside the skull, all the stuff that happens up here. Inside the skull and between the brain is still this layer of stuff that gets infected, has blood vessels, has important things that all travel with it, and those are the meninges themselves. What does this? Well, this happy little purple guy up here is strep pneumo. This is the most common cause of meningitis, at least in adults in the U.S. These guys down here are the ones that you actually hear about and the things that you might get vaccinated for. So these little red characters down here, that is Neisseria meningitis, which is a really bad the meningitis. The thing you get a vaccine for, that we're vaccinating college kids for, that's the guy there. Strep pneumo is one that out there usually causes like earaches and that sort of stuff. And then sometimes it can be viral too. This is echovirus. This is not COVID. This little guy here is echovirus. Does it really matter? No, it's just another type of virus, but it can cause inflammation of the meninges as well. Bacterial ones are the ones that are, the super deadly stuff where the kid dies within 6 hours of starting to feel sick. The college kid dies quickly that everybody hears about. There's probably tons of less or even, almost subclinical cases of viral meningitis that somebody just says, I have a bad headache and I've got a fever and I stay home for a few days. Although they can be quite severe, they can have severe complications as well. What do these guys look like? Sort of similar to the spinal epidural abscess. They have fever, they have neck stiffness, and then often headache or neck pain, and then altered mental status. Unfortunately, these are not also super common. They're not universal. Of the top three, fever, neck stiffness, altered mental status, which are the classic signs of meningitis, only about 2/3 of folks, when you look retrospectively at it, you could say like, oh yeah, he did actually have fever, neck stiffness, and altered mental status. But less than 1/3 of people will actually present that way, like initially. You don't pick that stuff up initially right away, except for about 1/3 of people. So, long story short, about 2/3 of people don't look the way that we're always told that meningitis looks. And then if you look at all 4 of them together, 99% of these people, 99% of people with meningitis will have at least one of these symptoms. But again, only like 1/3 have all 3, or even less, all 4. So while one of the presence of one of these should alert you, man, this could be meningitis, most of them do not actually portend to meningitis itself. So, fever, neck stiffness, altered mental status, and why do you get neck stiffness? Well, your meninges not only cover your brain, they also run down your neck. And so whenever you move them, whenever you irritate them or stretch them, like flexing your neck forward or turning it kind of to the side or something like that, rotating your head kind of back and forth will pull on them and irritate them. That, somebody in here, is that when you stretch your meninges, that's the thing that gives you the stiffness, and that's why people don't want to move it, and that's all the basic physical exam signs that's associated with it. So I'm just going to make sure everybody's muted here again. Give me just 1 second. There we go. Okay. How do these people look? Well, they look something like this. They look sick, generally speaking. I have not seen a true bacterial meningitis that did not strike me as like, oh man, that person's sick when they walk through the door. Again, it can be a little subtle, but the overall picture is that if you've seen a couple of people that look sick, these people fall into the sick category. By the way, they can also have, at least especially in the Neisseria realm, a rash, this purpuric rash. And this is not like a few little bumps on your skin or something like that. Just because you got a little fever, a mild headache, and you've got like a little red rash on your skin, that doesn't mean you have meningitis. But one of the really like bad findings that can happen with it is this purpley rash that basically looks like bruising. That's the best way to call it. It doesn't really look like the rash you see. It's like, oh my God, that person's got beat all to heck, and they've got a bunch of bruising under their skin. That is kind of a late presentation often. It's usually not the thing that you find first. So by the time you see the rash, you're pretty hard up to start with. There are some physical exam findings that they teach people about, and they are, again, basically if you stretch the meninges, like you flex the person's head, they try to pull their legs up so that you relieve pressure on that stretch. Same thing if you pull on their, theoretically, if you pull on their leg and straighten it out, they have tight hamstrings is what it looks like. These are what people are taught, and this is what we teach in medic school. If you really are looking at that, if you remember that one slide that talked about meningitis and Kernick sign and Brzezinski's sign, these are about 5% sensitive. It's a really terrible test. We shouldn't even talk about them, honestly, but it's probably something like 96% sensitive or something like that. So if you find it, oh man, bad deal, but only about 5% of people will actually have them. How do you make that diagnosis? We're going to stick a needle in your back and pull off some fluid. And we go in between the space in between your vertebra. This is, as bad as this sounds, it's not actually that terrible a procedure. I think people get freaked out about it. But if somebody comes up and tells you, hey, you need to have a lumbar puncture, it's not actually that bad. It's awkward and nobody wants to have it done. But it is a relatively small needle. Take the needle, put it into the space surrounding the spinal cord. You don't put it into the spinal cord itself, and you drip out some fluid. Hopefully it's nice and clear, but in this case of like meningitis, it often is kind of yellow, looks like it's got a little bit of pus mixed in with it. It's kind of cloudy. Now, cloudy itself doesn't necessarily mean anything. You have to send it off for cell counts, and we look at like what kind of cells are in there, how many cells are in there, what level of protein is in there, what level of glucose. And there's stuff that theoretically figures out how, based on your number of cells, like greater than 1,000 white cell, or greater than 1,000 polymorphonucleosites, and high amounts of protein because you're breaking down meninges and stuff, and low amounts of glucose because the bacteria are eating it all up. That's supposed to be meningitis. That's one way to do it. The other way is to just send it off to the lab and say, hey, run the meningitis panel, and they do this PCR thing where they look at the DNA that's in the sample itself, and then they come back and say, oh yeah, this is echovirus, this is enterovirus, this is meningococcus, whatever it is. So that's how we figure it out. These folks then get antibiotics. Antibiotics are really important for these folks because true meningitis, bacterial meningitis, if you wait to give them antibiotics, they get really sick really fast, and they get rapidly over the point where you can sort of bring them back with even really aggressive care. These folks basically need to get antibiotics usually within about 4 hours, if not 6 hours. After 6 hours, their survival is significantly worse for these folks. All right. That's, again, the basics of it. Let's talk about some of the frightening things I've seen that involve transfers for people that are suspected to have meningitis. Number one, should I put them in a C-collar? They got neck pain. No, don't put them in a C-collar. C-collars are terrible. Don't put anybody in a C-collar. No, these folks, really, there's no indication for that, and putting somebody in unnecessary cervical immobilization not only is the wrong use of the wrong thing, essentially it's the wrong drug for the wrong reason in the wrong setting. It's got all the R's that are bad. But no, these people don't need a C-collar. They need antibiotics and good care. Should we move these people without checking finger stick? Remember, fever, altered mental status is one of the hallmarks of this, and most of these folks are at least a little bit altered. There is more than one person I've seen that's been transferred a long way, relatively speaking, for what was presumed to be meningitis and was found to be, well, maybe there's meningitis, but more so their blood sugar is 20, and that's probably why they're altered. So anybody that's altered, check a finger stick. That goes without saying, but just because somebody has said this person has meningitis, if they look funny to you, you should probably check their blood sugar before you take them out of whatever bed that they are sitting in, because it'll come back and bite you. And maybe initially even they weren't like hypoglycemic, but they can get that way. So don't move these people without checking a finger stick. Anybody that's altered, make sure you got a current blood glucose. One that's done 6 hours ago when they first got to the hospital is not sufficient. How about transfer these folks without getting antibiotics? Now, this isn't necessarily your responsibility, but it's sort of your responsibility. If you're going to be taking them 2 hours down the road to a tertiary care center and they haven't gotten antibiotics, but somebody says, we think this person has meningitis or we think this person has an infection in their brain, they needed some antibiotics to start with. And it's also not okay to say, well, we're not really supposed to transport antibiotics. Should we? We can just DC this for the moment, right? They can restart it there, or they can give the antibiotics there, right? No, this is the time when, like, if you think the patient has meningitis, they got to have antibiotics now. So they need to either stay at the hospital to finish their antibiotics, or they need to be transferred with antibiotics if it's not complete. It's not okay to say, well, we'll let the other hospital take care of it. Not the case in meningitis. Many other things, yeah, probably antibiotics aren't, as critical as like a pressor or something. In this case, they got to get them antibiotics before you transfer them down the road, or while you're transferring them. And if you can transfer them with it in place, cool, perfect. But don't move these folks. Somebody that's suspected of having meningitis, don't move them until they've gotten some antibiotics, or you have a plan that they are getting them. So another one that we saw, suspected meningitis or encephalitis. They had a seizure en route. Crew was worried about giving benzodiazepines because, well, their mental status was a little bit suppressed to start with, and so we didn't give anything for it when we noticed that he had a seizure, and we just let him seize for the last 10 minutes or so. Of course, you roll your eyes and you're like, oh my God. But of course, that happens, and folks get concerned about things. So let me just be the first to tell you, these folks sometimes do have seizures. Even if their mental status is depressed, you got to stop the seizure. Stopping the seizure is a really important thing. You can think about like setting fire to your brain while it already has an infection. That's basically what a seizure is doing. So you got to stop that seizure. When it happens. And so, yes, giving adequate doses, good doses, strong doses of benzodiazepines in order to abort that seizure, super important, because a seizing brain, when it is infected, is not helping anybody. And if you got to manage their airway, okay, manage their airway, because that's the worst thing that's going to happen when you aggressively treat these guys as seizure. Now, let's go back to the case at the beginning. Do you need to get antibiotics yourself? You transported a patient that was later found to have meningitis of one way or another. You're called, the hospital says, hey, this guy had meningitis. You better get yourself checked out. Well, what does that actually mean? There are some cases where folks that are close contacts of people with meningitis need to get treatment or prophylactic stuff, post-exposure prophylaxis. Now, for most of the time, again, if you remember what I kind of said before, the things that cause meningitis in most adults in the United States, it's either strep pneumo, which is one of the bacteria that is commonly out there, and you do not need prophylaxis for it, or listeria, which is one of the bacteria that is also out there, and you don't need antibiotics for it yourself if you're exposed to them. It's really only the Neisseria, the classic meningococcus, that big bad one that affects college students and kills them in a few hours, that sort of thing. Not that strep pneumo couldn't kill you, but the one that we always talk about, that is the one that folks need really post-exposure prophylaxis for. And often this is like a dose of Cipro or something like that. It's not like you got to take it for months or anything along those lines. The recommendation is that if you're exposed in that you are close household contact, or like you live in a dorm room with somebody who's got meningococcus, or you're exposed to respiratory secretions. So even riding in the back of the ambulance with this person doesn't necessarily mean that you need a dose of prophylactic antibiotics. If you intubate them, or if you suction their mouth or something like that, then you come in contact with their respiratory stuff, and yes, in that case, you should probably get a dose of prophylactic antibiotics as post-exposure prophylaxis. That's the story on who needs antibiotics, even if you're feeling well after exposure to somebody with meningitis. So most of the time, not something that you actually absolutely have to have.